So we have it for everybody who's not here. And I will go ahead and start sharing the presentation. All right. So thank you everybody for coming. This is going to be our data preview for our Barry CHNA. So we've been doing this for quite a while now, and this is kind of our second to last big meeting ahead of prioritization before we transition into our CHIP work, our community health improvement work. So just to go through today, I'll just go through for people who haven't been here before, kind of why we do this, what the process looks like, what we've done so far. Then we'll dive into the preview and then just talk a little bit about what comes next. So first and foremost, like, why do we do this? Well, assessing health is pretty much one of the things that public health does. It is kind of core to what we do. It's one of those things that if we want to know how to act or who to bring to the table to address a problem, we have to know what the issues are. And that's gotten a lot easier in the past probably decade or so, now that there's a lot more data out there, a lot more things are data driven. So it makes it a lot easier to do that, and a lot more people have that data available, which is always great. And at the same time, at the passage of the Affordable Care Act in 2010, that set forth some requirements related to the IRS for hospitals to maintain their nonprofit status. And also the Public Health Accreditation Bureau does a national level accreditation that a lot of health departments, local health departments are seeking these days, and a lot of those requirements overlap. So it did make a lot of sense for the local health departments and local hospitals and hospital systems to share the resources and work together to do that assessment and to do that planning to improve the health of the community. Essentially, this picture just goes over what the cycle looks like. So we are starting at the top. So the community health needs assessment, we ask that question, how are we doing? The data then gets pulled. We go through it, we analyze it, we have this party, this data preview. Once we go through it, we will have another meeting that discusses the priorities. So we'll have a vote on that next time. So we'll go through like a list of kind of categories and talk about, which ones we think are worth it. And then we'll have a final vote, and we'll probably choose between 4 and 5 categories to go forward with for the hospitals, the health departments, local partners to try to address collectively. And then that leads into our improvement plan. So those priorities are taken, and then a plan is developed by people to basically say, what are they going to do to improve it? We'll implement those actions. We'll kind of continuously monitor and evaluate how it's going. We'll update the data, and we'll do the whole thing again. At this point, the cycle is once every 3 years. So we spend about a year doing the data update and the assessment, and then we choose our priorities, and we spend the rest of the time implementing the plan, and then you doing monitoring evaluation before we start again in 3 years' time. To sort of shape how we addressed, or more of a framework. So the framework we chose is county health rankings. So it just breaks down the different factors and how it's another way to look at health. So they themselves list more than 30 measures to help people understand how they are judging health based on the breakdown you see. But we use this as kind of a loose framework. So we used it as a starting point. And then after that, we kind of chose and came to the advisory committee. So that was our first meeting, our kickoff, where we chose all the different measures that we would include going forward. And then we sort of mapped them to the different areas in the framework and went forward with that. So where are we now? The first part, the quantitative data, that is our numbers, or the different data sources we pull. So things like the American Community Survey or census data, vital statistics, those sorts of things. We have pulled at this point everything we need to pull. We are in the process of analyzing all of it and writing it up for the final report. The qualitative data, those are our stories. Usually those are focus groups, except this time we had a lot of trouble with COVID and just getting people who were willing to share their stories. But we were able to have about 8 one-on-one interviews with folks. So those had been completed as of a couple weeks ago. And we have completed analysis and started pulling quotes for that. And the goal is to have a final sort of narrative that explains, goes kind of question by question, and having an overarching narrative supported by those quotes and those insights shared with the community. The interviews for the one-on-one interviews are typically aimed at folks who are generally medically underserved. So folks who might not have the best health insurance, who are in recovery, who are unemployed, have a disability, those sorts of things, getting those really important voices that sometimes are maybe a little bit marginalized compared to the rest of us. The other thing we've done is an asset map. So that was also decided by the advisory committee group. So it was decided that we wanted to focus on economic factors. So we landed on having a map of large employers, the places that provide upskilling or resources to kind of improve their abilities, and other employment resources like Michigan Works and those sorts of things. We were able to partner with Barry-GIS. They helped us develop that map. So we thank them for that. And we will preview that in just a little while as we go through a couple other things. So we've also been sharing these things as much as we can through Facebook posts. I've been trying to email out. We've gotten our advisory committee meetings. So those are the kickoff meeting, the asset mapping meeting, and now today is our third one. In between those, we have done our community survey. So we had about 400 responses, which is a very, very good response rate. And then we did our provider survey, which had about 40 people respond, which again, compared to last cycle, was a very good response rate. And then, as I had mentioned, we had done our interviews, and those have been completed as well. In terms of publication, the final product will be available sometime in late December. So we hope to have that to you slightly after prioritization, which is the last thing we will do before we see that. So the prioritization meeting, hopefully you've already seen an invite for that. It went out at the same time as this invite, and we will put that in the chat at the end just to make sure everybody has it. We'll send some more invites to folks to make sure they didn't miss it. But that will be December 13th, and I believe it's around the same time, so it should be around 1 to 3, but I'm not 100% on that. And asset mapping. So this is what I had mentioned just a minute ago. The focus again on economic factors. So those large employers. So that's I think we focused on over 50 employees. So on the next map, I'll just bring that up. Those in blue are the large employers. Those in purple are the resources. So those includes things like, and I also include libraries, Michigan Works, schools, and those sorts of things. In the final product, there will be a large table with all of their contact, I don't know if it's contact information, but location, address, possibly a phone number, and kind of what they do. So the type of resource they are. So look forward to that. And now on to the reason we are here, the data preview. So essentially, we want to do this because we want to get everybody here familiar with the data before we head into prioritization. We want to give folks the ability to reflect on it, to discuss it in this meeting. So at any point, if you have a question or you have an insight, please feel free to share it. We will have a few questions and stuff drawn out throughout to make sure people are thinking about it. But it is just a way for us to get as much feedback as we can heading into the final publication. So, feedback can be things like, do we feel like we missed anything? Do we feel like we're not painting a complete picture? Do we think something is there that is or should be there that isn't, or is in there that maybe shouldn't be? And that is kind of how we do this. So the data preview is just a way to get all that in front of you and ask those questions in a kind of a systematic way. And with that, we'll jump into our first section. So that's health outcomes, and we'll focus on length of life and quality of life. So for each section, we'll start with a little table like this. So we'll have our measure on the left, the definition of what it is, and then a comparison between Barry County and the state, if that is available, and a kind of quick comparison. These slides will be sent out after this meeting and in preparation for prioritization to give people an idea kind of where things stand before we head into that for those who weren't able to attend as kind of a quick little shorthand. So the first four we'll be going through are premature death, mortality rate, infant mortality, and suicide rate. And in terms of data sources, these are all a mixture of our own. So Barry-Eaton has our own behavioral risk factor survey that we complete. It is a 3-year survey, so our last one was published in 2019. We're in the middle of doing it again. So that gives us some really good data, and we're really proud of what comes out of that. But we also use things like MDS or not MDSS, MDHHS, vital statistics, and the state has a lot of very useful resources for data, as well as the American Community Survey for population sort of data, because the census always has really, really great data. Our first measure, so that the years of potential life lost before 75. So for this one, we can see that Barry County is lower than the state of Michigan, which is great. So all of these graphs will have a kind of comparison there, shows kind of the direction you want to see it. So worse going up, or in 1 or 2 cases, you'll see better or more equal going down. So that's just to make it clearer for everybody involved. Excuse me.
Can I just jump in and say, so the way this is done is that they take, essentially what's the life expectancy, which is about 75. And then anyone who dies before age 75, they subtract 75 from that person's age or vice versa. And those are considered years of potential life loss. So if you have something like a teen suicide, that's going to be a ton of years of potential life lost as compared to somebody who dies when they're 70.
Yes, that is correct. Thank you. And then they turn that, so since it is per 100,000 residents, they turn that essentially into a rate and age adjust it to give a comparison to different population sizes. So similarly, mortality rate, a little bit lower than Michigan overall. So this is just the age adjusted mortality rate, again, as a rate per 100,000 residents. Pretty similar, not too far off. It seems to go up and down a little bit, but relatively even, not too far off. The infant mortality rate. So these are taken over 5 years. These are all, so infants, anybody under 1 year of age. And then we had to do a 5-year average. So it's kind of a rolling 5-year average. So that's why all the year breakdowns are down there at the bottom. And you can see Barry County is doing pretty well. They are on a pretty nice decline from about 2006 to 2010, that time frame, until last year. So that's some good news. And then our last slide for this section, suicide rate. This is, again, a 5-year average, and you can see that it has remained elevated in Barry County for quite a while. So since about the 2008 to 2012 window, and then peaking in 2012 to 2016, and starting to fall again now. But during that whole time, still above the comparable rate in Michigan. And that brings us to our first question. So I think I'm gonna try to launch a poll, and we're gonna say in the community survey, one of the questions was, or problems listed was suicide. So what percentage do we think Barry County residents listed suicide at? Was it 11%, 7%, 2%, or 13%? I'm going to give it like 5 more seconds. Okay. So 2 people had the right answer. It was listed as 2%. So a little bit surprising, given that the the rate is a little bit higher than the state average. But does anybody have any feelings as to why they think that discrepancy might be there?
So I would say, I think, you know, suicide, while it's very devastating, it is fairly rare. So I think maybe people's perception of this as a problem, while it's a severe problem, they may not see it as affecting as many people. And Liz says respondents haven't been impacted by suicide personally. I think that's kind of sort of along the same lines as what I was saying as well.
Also, I was thinking about how, you know, the way that the question is worded, you know, if it's listed as suicide, so is it a suicide that actually happened? You know, so like, are they considering attempts in addition to that, or just an actual suicide that happened?
So it would be I believe the term is completed suicide. They would have lost their life. So not attempts. And also one of the things that stood out to me when looking at it was there was a lot of, you know, some of the things we'll talk about later in the community survey, but you know, there was the affordable access to behavioral health services was rated very highly. So, you know, there are those things, and alcohol and drug issues, you know, they can be related, but specifically calling out suicide was at a much lower rate than I was kind of expecting going into it. So yeah, I just thought it was interesting to see the discrepancy there between what the data showed and what the community thought. Anybody have any other thoughts before we move on a bit?
I'm just surprised. This is Kathy Forsyth, because it seems to be a topic that at least the last 6-8 years, at least in the Delton area, a lot of people have talked about. I'm surprised that it was rated so low. I wonder who answered the surveys? Was it sent out to everyone, or?
That was another potential reason that we could bring up. So this was an online survey done through RedCap. So our partners at Spectrum Health and Spectrum Health Penic used RedCap to send it out, and we distributed kind of QR codes and links to folks at our sites, and just getting it out there in the public. So certainly, you know, the demographics who respond to that may be more or may be likely to underreport it as a concern. That could be a potential as well.
Yeah, it wasn't a random survey.
Right. It was a convenience sample.
And then Dawn, I think, brought up a good point about the stigma. I think that you know, impacts something like suicide, that, you know, it really could be something that people aren't talking about as much as maybe it's really impacting the community.
Certainly. All right, thank you, everybody. And with that, we'll move on to our second set of health outcomes. And this time we'll focus on quality of life. So here we'll see diabetes prevalence, poor mental health days, and poor fair health days. And these, I believe, all come from our behavioral risk factor survey and being compared to the Michigan State Behavioral Risk Factor Survey. So we can see here that it looks to be on the top of it that Barry County does well for diabetes and is about equal on the other two. So let's jump in. So for diabetes, you can see the responses over the years. So for some reason in 2015, we seem to have a pretty big sample of folks that responded they had at some point been diagnosed with diabetes compared to the state. And then for our last cycle, it came down a decent amount. But more importantly, just to give everybody an idea, we do also have the ability to break this down by income level and some other breakdowns as well. We haven't done that for every single one, but it is important to remember when looking at these that even though the top line is sometimes points to you know, having a good standing and good data in comparison to things, there are still pockets of folks in different demographics that will have more of an issue with things than others. So even if those top lines look good, it can still always be useful to look down into the breakdowns to find all those different things. Sorry, choking a little bit, as to be more informative. And so another question that I'll do a quick poll on, our chronic diseases. So that was another thing listed by folks in the community survey. So where do you think that chronic diseases overall, so not just diabetes, but things like high blood pressure, heart disease, those sorts of things, where it ended up? Looks like people are figuring this one out. All right, so yes, most of you were right. So about 8 people chose top 5, and it came in at number 4. The other top 3 were mostly related to mental health and access to care. But yeah, so it's chronic disease still a major concern out in the community as well. So good guess, everybody. And poor mental health days. So this question is worded as having 14 or more poor mental health days in the last month. And again, this is for our own behavioral risk factor survey. So in the years 2011 to 2013, when this was done, there was a change in the wording. So that's why that year is missing. But you can see a pretty steep increase from 2014 to 2017 to 2019. So does anybody have a feeling as to like why maybe that has jumped up so much in the last few years? Whether it be you know, job losses or kind of, I don't know, any reason at all.
I'm kind of wondering, oh, Jillian, did you want to talk? Sarah says social media and screens. My suggestion was going to be possibly identification of, you know, more people willing to recognize what they're going through as mental health issues.
Education to kind of be a lot about education around about what mental health and wellness is.
Certainly. So it is definitely more, but I would say less stigmatized to discuss than it has been in the past. And I think in that time period is absolutely when a lot more of that had started happening. And I did also want to highlight one of the quotes we had from our interviews. So that's what you see there on the side. And this person was a senior citizen, and they felt that even though they had a good social support network, they didn't feel that, you know, they know a lot of people who maybe feel a little more isolated and lonely and left out. And so they wanted to see more to do to promote the Commission on Aging and things around senior resources. So is that something anybody has seen as well?
Oh, well, Chris, this is Rich from Barry County Community Mental Health. I think that's in general a concern with that population as they age and have less contacts, right? Less social interaction. They're not as they adapt to using technology maybe as the younger generation. So I think that's always a concern. I'm just wondering, curious if you had enough, if the N was large enough to break it out by demographics, because I forgot who mentioned about social media, but we have seen an increase over the last few years of increased link to depression and anxiety and things of that nature with,
So, sorry, go ahead.
I was going to say with the younger generation, and especially female and younger generation.
That is where I was gonna go ahead and take that. So this specific slide is for adults, so everybody 18 and older. There is, I believe we have it now. I'm just stuck thinking if we do or do not. In adolescents, there is a similar question that we can get through the MiFi that we pull that would have. I don't know if that specifically has the breakout on screen time, but I do know they report symptoms of depression in the last 30 or within the past year. So this specific slide is only for adults 18 and over.
Yeah, and Liz had a good comment about, this is, and most of the data that you're going to see in these presentations is pre-COVID. And the reason for that is just this data takes a long time to get. Vital statistics, it take at least a year to 18 months. And then our BRFS is designed to only survey a third of the sample every year. So we can't pull a decent, we haven't surveyed enough people yet. We've only surveyed, somewhere between like 50 and 60 people. So I absolutely think this is, just based on other, information we have, that definitely COVID did not help with any of this, for sure.
Absolutely. And we'll move on to our next one. So poor physical health. These are folks who, again, we're asked the question, do they feel like they, how's their general health? Do they feel like it's good, okay, poor? And it's pretty even there with the state. So you've seen it go up and down a little bit as we've asked the question. Again, going down from last year, but that previous year up significantly from there. So maybe a little bit of just variance within the sampling. Our next big group, so this is probably our biggest group, will be health factors. So we're going to look at a few different things here. So obesity, food insecurity, drinking habits, and smoking habits in adults and adolescents. So with this, we'll just jump right in because it's pretty long. Perhaps surprising nobody, obesity continues to rise for pretty much everybody in every place. It looks a little bit smoother for the state just because of a larger sample, but we do still see over the last 3-year cycle that it has increased as well. But we are within that 1% from Barry to the state, and it has decreased from the last one as well, which is fairly interesting. When considering adolescents, again, it's that gradual rise there. We're seeing that continuing both in the state and in Barry County. It just keeps on, same issues are there. I think surprising nobody. Access to food. So this is our who lack adequate access to food. So this isn't just referring to food deserts. So not just talking about where the the closest grocery store is. This is at any point during the year, somebody was uncertain of having or being able to afford the food they need or to meet their needs, or if they were worried about having the money or having to make trade-offs between that. So interestingly here we see a slight increase in the trend from 2017 to 2019 in Barry County, and then the opposite trend of going down a little bit in the state of Michigan. So I'm wondering if anybody here has any insight as to why they think we might be seeing the opposite trends here between Barry County and the state.
This is Kathy. This is through 2019, right?
Yes.
Yeah. So I think it may have gone up gradually then, but I think we've made huge strides in the last 2 years that it's definitely not a problem anymore. I see so many, I work with a lot of at a free clothing outreach and the fresh food initiatives that are all around and the schools and stuff. I really think that this has got to, at least at the next survey, I think this is going to definitely take a dive.
Chris, what's the data source on this?
This is from Feeding America. It's mining the meal gap, and they have a map that shows all of it on the website.
I wonder if it's USDA.
So it uses the USDA's definition. I'm not 100% positive it pulls the data straight from there.
Okay.
Okay, so we'll move on to binge drinking in adults. So again, we see with our BRFS, it seems to be a pattern now. We see years go up and down pretty regularly. And then in the state, we see kind of a decreasing trend over our last 3 cycles. And kind of, we went down from 2014 to 2016 into our last cycle here, down to 12.6%. I find it interesting that this is self-reported, so that is part of maybe the quote unquote issue here. But with the community survey, alcohol and drug use was fairly high. So I'm wondering if anybody would be able to share any thoughts on the discrepancy between, seeing a high priority given to problems impacting it and being in alcohol and drug issues, and then what seems to be a lower prevalence of binge drinking in adults in our risk factor survey.
This is Liz, and I wish we had newer data. I'm feeling some frustration. First of all, I don't necessarily believe that this is the 12.6 rate. And I want to be sure that we all use the BRFS data sometimes because of the way that it's the best data we have. But I would say that there's other, the Substance Abuse Task Force conducts community surveys, and we did one in 2019 and again in 2021. And, kind of the impression we're left with, as well as some of the information that's come out federally regarding trends, is that drinking during COVID especially is probably much higher. It's been a coping skill that's been used. And I would say, I think it's just the luck of the draw of the people who chose to respond to the survey at this point. One of the things that we're finding in our work is that the people that really need to take the survey are not. And Chris, I know you and Ann deal with that all the time, is that sometimes just kind of honing in to the sweet spot to get the actual people best suited to answer these questions, they aren't the ones that respond. And again, for me, I would say that the data is going to be much, much higher based on 2020, 2021, based on some of the data that the Substance Abuse Task Force has been looking at and that we're familiar with that comes in from other sources. I don't think it's representative at all.
I mean, I would agree. More current time, I would certainly agree. We do, unfortunately, the timing of this cycle is just such that we weren't able to complete the survey before the cycle of this. So this is kind of the data we have.
But that's why we're having these meetings, though, and that's why we're also doing our community survey. So thanks for that, Liz. And I think that certainly we've heard from people on our on this survey and the work that you guys have done is that this is a significant problem. And the other thing too is that when you compare us to the state, well, we might not be worse, but that we also have to ask ourselves, is this an acceptable level of this behavior? And that's is it causing a lot of harm in our community? And I think that's also really important to keep in mind.
Certainly, and with all that in mind, going ahead, our next slide is the binge drinking in adolescents. So a little bit of that same kind of up and down trend that we've seen, but a pretty good decrease there over time. So Liz, I don't know, do you have any insight as to what maybe the difference there is between adolescents, so this is just high school students, and then compared to adults?
I do have some insights, and the insight is that, the largest regret for me of COVID is that because of the nature of how schools in Berry County, I'm assuming this is MiFi data. It looks very familiar to me. And MiFi in the culture of Berry County schools is they all have their own times of the year that they like to administer the survey. And in 2019-20, nobody completed it before they got shut down.
Yep.
And so we have a data gap. And what we were seeing was this really good trend of binge drinking. And we tend to look at the 30-day use. We don't always look at binge drinking. We look at 30-day use because we think that that's, enough of an issue with our young people. Binge drinking is a little bit defined a little differently. And the numbers were coming down. And that's good. But at the same time, the numbers that were going up were youth use of the numbers that were going up were youth use of marijuana in over 30 days, and the one that hits the sky with it was youth use of vaping devices. So we are helping schools administer, as much as we can. We're encouraging schools to administer that MiFi data or that MiFi survey for 2021 and 2022 because we need that data. And most of us think we're going to see continued increase in marijuana and vaping only because that's the trend amongst teens right now. Alcohol is still happening, but it's not. It's kind of a systemic change. So I probably have talked too much. So I'm going to shut up now.
No, but you did bring up a very good point, and that was one I was going to mention as well, is that they did not get to complete that MiFi survey. So there is some of these on at least the high school level, the adolescent level ones that we have, there is that gap for the last cycle. And they should be doing the new data soon-ish, but unfortunately not in time for this report. So, we'll have that going forward into the next one, but it would have been really helpful to have some of that insight, especially leading into COVID. I think would have been really some fascinating data. Does anybody else have anything they want to add to that?
I was going to share that I think binge drinking is different than like alcohol problem. Like binge drinking is an activity versus not an addiction, right?
Sure. So the binge drinking definition that is used is, was it 4 or more drinks within a couple hours for females, and then 5 or more for males in the last 30 days versus just have you used within the last 30 days. So there is I don't think there's one that is used as like a how frequently do you do, but yeah, you are correct. I mean, it is a little bit different probably in maybe high school, college age students than adults, where maybe it's more habitual, but there isn't a great measure that we are able to compare adults to kids with and having those similar things other than the ones we have right now. And Liz, thank you for bringing up smoking. That is going to be our next thing. So our current smoking percentage in adults. So we see it's actually been pretty steady outside of, so this is just tobacco, to be clear. This is just have you smoked a tobacco cigarette in the last 30 days. So for Barry County over time, it's remained pretty steady from between 16 and 17% through all cycles except for that one dip. And then in Michigan, we see it coming down. And before we discuss, I do want to also show in high school students. So we see it dropping pretty precipitously. And again, there is that gap, unfortunately, for 2019, 2020. But we do see in Michigan the last year available, that it does increase slightly. And then maybe unsurprisingly, a breakdown just by grade attainment. We do see kids who are struggling doing worse overall, but encouraging to see that there is a pretty steep downward trend there, which brings me to my next question. So do we feel like the ones we just saw for both adolescents and adults who reported smoking in the last 30 days, is that a complete picture of smoking and any progress we've made or any concerns there may be, or are there other factors?
Chris, it's Liz again. I definitely want to talk, but I want to let other people talk first.
That's fine. Anybody want to jump in?
I wonder, I mean, one thing that I think could be an interesting metric is not actually the number of people using, but look, and I don't know if the tobacco like tax base would be able to tell us this, but how many packs of cigarettes have been sold in Barry County at different year intervals? Because I think that's another metric that could get us not to just how many people are using, but how much tobacco is being used.
Sure. Anybody
Yeah.
have anything else before Liz starts?
Well, I'll just say that I think this is a leading question, Chris, because I think what was missing is vaping.
You got me. You got me. Yes, that is. I mean, that is where I was bringing that is Liz, as you had alluded to earlier, that vaping becoming much more of an issue. So if you want to say a few words about that, go right ahead.
Yes, my definition of a few words and yours are probably different, so I'll be brief and succinct. This is missing relevancy to the current situation. The nicotine behaviors and nicotine usage patterns are changing. We no longer really, I mean, we still have people that use traditional cigarettes and forms of tobacco, but we're having to be inclusive in our language to realize that it's more of a nicotine use now and that it's completely different. And we need a good, we're starting to get a feel for youth vaping. And we think that's underreported at 30-some% based on 2018 data. And I don't know whether the BRFIS even asked about vaping. I think it was starting to ask, wasn't it, Anne?
It does, yes.
Yeah. So, I know that when I'm out and about, I see an awful lot of young adults and adults vaping. And I know that vaping is a humongous issue in schools right now. It's probably one of their number one concerns.
Exactly. So we are at that point probably where the questions are asked separately. So whether there's the methodology change in the question going forward, whether it's on our behavioral risk factor survey for not this cycle, because we didn't make that change for this cycle, but the one following, or if the state decides to change that, we are getting pretty close to probably needing to change that question to really look at the full picture, because even reporting them separately may still not paint the complete picture there. Any other comments on? Okay, go ahead.
I was just gonna say that I think one of the things for the final report would be that we need to, throw a little mini chart in there of vaping, at least for adolescents. And I don't know if we can do something with from BRFS, but I just think I don't think it's as good as if we just show, tobacco cigarette stuff. So there's my plug for that.
Thank you. All right, so we are just about halfway done now. So we're gonna take maybe, let's say, a 5-minute break. So I have 46. So how about we come back at 51 to finish up, or unless everybody wants to keep going, I think we'll take a break for right now. All right, so see everybody in a couple of minutes. Our second half of the slides. Our next section up is health factors, and specifically relating to clinical care. So here we're looking at preventable hospital stays. So that's our classic Medicare hospital stays for ambulatory sensitive conditions, with the last year being 2018. Persons who report that they do not have somebody they think of as a primary care provider, and then looking at the mental health provider ratio, so that the population per mental health provider. So some good news in the last few years is that it seems that hospital stays in Barry, preventable hospital stays for Medicare patients has been going down, which is always good to see, while it has remained fairly steady throughout Michigan. I don't know, does anybody from the Spectrum team have any insight as to, I mean, I guess COVID's probably masking some of that, but if you can think back to around 2018, if it seemed like it was getting any better as related to those kinds of hospital stays?
You know, I don't recall what year it was, but we did form a partnership with Thornapple Manor with our hospitalists going into the facility to help treat to some degree there. And if Don's still on the phone, maybe he or on the call, maybe he has some more insight as well.
What was the question? I'm sorry.
Preventable hospital stays.
I was just wondering if somebody if they could remember back to 2018 before, you know, everything we've been going through, if it did seem maybe like those kinds of hospital stays, the preventable stays were going down, and if there were any interventions that maybe had occurred that had helped.
Well, we actually wrote a paper on it, yes, because we had shifted our medical director to the hospitalist at Pennac. So Dr. Erbter became our medical director. And we saw a significant drop. I forget what the rate was now in readmissions to the hospital as a result. And more importantly, we saw some nice things, like we had the last thing that the hospital did before they sent them to us was do a blood draw and lab test, so they knew where they were at when they been discharged. The first thing that we did when we got them here was to do a blood draw and a lab test, so we knew where they were at when we got them. So we're literally poking the resident twice within, you know, an hour, which didn't make sense. And so we're not doing that anymore. We're just accepting the lab results from the discharge at the hospital. Secondary to that, you know, it used to be pretty standard when we sent somebody to the hospital, they would DC all their medications and kind of start all over. And they don't do that anymore. They know why they're on the medications. They may adjust medications that are, you know, a direct result of the acute condition that they're in for, but they don't play with all of them anymore, which is really nice, because that had caused some problems for some residents on those medications that you have to wean them off slowly on. So we've seen a lot of benefit from that. And then the article on our reduction of discharges or reduction of readmissions to the hospital was written up in the Healthcare Financial Management magazine monthly, and was up for an award at Spectrum in Grand Rapids based on the work that, you know, Steve and we did when we did all that. So and then it dropped significantly during COVID because you didn't want us sending anybody out there, so we had even fewer during that time. But it kind of came back up a little bit this past summer, but now it's, I'm sure, down again because hospitals are full and there's nowhere to send them anyway.
Yeah, so I mean, certainly in the next few years when this starts to come out, it'll be interesting to see how that bears out and how COVID and everything played into it. Because like you said, you know, when they're so full with one specific thing, it does sort of maybe make those, you know, fringe hospitalizations that maybe weren't necessary, probably keeps them out a little bit more so than maybe you would think with everything going on.
Yep.
And somewhat related for our next slide. So these are people who report they do not have a primary care provider. So we've seen a really nice downward trend here. And then kind of a little bit of the opposite for Michigan. So I don't know, does anybody, again, Spectrum or anybody else who has a feel for primary care providers, what's driving the decrease there for people who don't report having a primary care provider?
Hey, Chris, this is Emily, and I work with our primary care providers for Spectrum Health. Unfortunately, we are in a shortage area in Barry County specifically, but we do have access in many of our clinics still for new patients, and we're open to accepting new patients. So We really need to focus on wellness in the community and trying to drive patients to seek primary care providers rather than just seeking urgent care when they need it specifically. So a huge piece of education is what we've been trying to push in Barry County specifically around that.
So are there any,
And
I
the-
mean, I guess, okay, sorry, go ahead.
I was just going to add, I think the timing of this, I think there's a couple things, possibly the Affordable Care Act, providing additional Medicaid opportunities for people. And then also the Cherry Health. I think they, Health Connections was around before that, but it really isn't at the scale that Cherry Health is. So I think those are probably things that have helped.
I think also that people without insurance, I've known quite a few over the past dozen years, and I don't even think primary care provider is even in their vocabulary.
So I will say, this will be one thing I bring up when we discuss the community survey. So one of the questions we ask is, are there any barriers, or do they feel like there are any barriers to getting their care? And, perhaps this is one of the people, those types of people who responded, was that they didn't feel like there was an access barrier because they could go to the emergency room if there was anything really wrong.
That's
so
exactly.
I think that's, yeah.
It's bad, but it's true. And so they don't even look at it as having a primary care provider as an option.
Exactly.
Chris, one other thing that over the last, I think we're on our 4th year, working on the SAMHSA grant with Cherry Health. So the purpose of that grant is to integrate behavioral health and physical health. And so we partner with each other to, obviously, if somebody shows up at our door, it's kind of a no wrong door kind of a concept, and they need primary care, we connect them with Cherry Health, or if they have somebody they just haven't seen, part of that grant is also increasing the coordination with the PCPs in the community. So there's been quite a bit of collaboration between ourselves and Cherry Health, trying to make sure people are connected to a behavioral health provider and a physical health provider. We also just, with our new CCBHC grant, hope to continue that as well into the future.
Thank you. So while we got you there, our next slide is mental health patient to provider ratio. So for 2019, we can see that there is still a pretty big gap there. And if I'm remembering correctly, we had, looking at previous years, it has improved over time. So I was just wondering if you could shed some light on that.
Yeah, I guess my first question is how are we defining provider? Is that just like a psychiatrist, or is that like including like the therapist as well?
Oh, that's a good question.
I will
I
look
don't
that
have
up
it in
and get
front of
back
it.
to
Yeah.
you.
Okay.
Thank you.
Both of which are problematic. Just the one is more problematic. The docs are more problematic, or securing a psychiatrist.
Mhm.
So this is definitely a problem. We've trying to secure or bring individuals that are properly credentialed and licensed into kind of a rural community and setting to address behavioral health needs. So part of that is the SAMHSA, the CCBHC grant that we've recently got that hopefully will help with that. But we also have kind of connected with regional partners, local politicians. I've talked with a lot of people that spend the majority of their time at DC. So some of this is related to how, I'll say, like how other states do their credentialing or allow certain providers to do certain works, certain actions. And Michigan is a little bit more restrictive in some of those areas. So if we can get some focus on licensing, reciprocity between states, things like that. Like I said, Barry kind of also sits between you have Grand Rapids and Kalamazoo, kind of a couple bigger metropolitan areas that kind of draw and have more resources. So that's always a factor as well.
Now, since this is 2019, what's your feeling on how it's kind of progressed over the past few years? Like, has it gotten better, or is it kind of feels like it's around the same?
One thing I can speak to regarding that, because this is pre-COVID data, I will say that the ability to get providers, there's a nationwide workforce shortage for clinical providers right now since COVID. So that comes up on every discussion with any group I have, is about how difficult it is to get properly credentialed therapists at this point in time. Unfortunately, that's also coupled with numbers going up, not so much in year 1 of COVID, but in year 2, we've seen a huge increase in requests for services. On the positive, one of the things that I think is probably reflected in this survey pre-COVID is that the mild to moderate mental health population was very difficult to connect with providers, and community mental health was funded to serve the severe and persistent mentally ill. And that was actually one of the hallmarks that we wrote our CCBHC grant on. And so once we get that into place come January 1st, we actually are able to see that population, provided we have sufficient therapists to see them. But so I think that's where some of this comes from, is that we've known for quite a while in Barry County that for the mild to moderate, particularly those with Medicaid, that there wasn't a whole lot of options for care.
Thank you. Anne, were you able to find the definition?
Sort of. So the mental health provider ratio comes from the NPI registry, which is providers who would have an NPI number. So I'm not sure if that would be master's level therapists or not. Possibly.
They do. Yeah. Master's
Thank you.
level therapists do have an NPI.
That's
Okay.
helpful. Thank you.
Though I want to say, I think bachelor's level providers might also have an NPI. So
Yes, virtually everybody that works at our agency at least qualifies for an NPI, even down to our peer support specialists. So I'm surprised that if it would just be the fact that somebody has an NPI,
I
because
think
that's very broad.
Yeah, and I think it's those who are billing, but I don't. But again, it's going to take a little bit more digging.
Okay. Well, we did get a good discussion, so thank you for all of that, and we'll move on to our next section. So that'll be our health factors and focusing on social and economic factors. So for these, we have our disconnected youth, which are folks who are 16, 19 years old and neither working or in school. Level of educational attainment, access to broadband, and I do have the definition for that as we move on. Household or percentage of the households who are below the ALIS threshold. So it is asset limited, income constrained. I can't remember the E, unfortunately. And then overall income inequality. So first, we can see that there has been a pretty significant increase over time, pretty steady increase over time in Barry, even though it has dipped from 2018 to 2019 when compared to Michigan. And for this one, I did go ahead and break it down by gender as well. So we can see here that it's actually pretty interesting. So we can see kind of the reverse and in kind of an order of magnitude more for disconnected, those 16 to 19-year-olds who are female in Barry County compared to Michigan. So my question for everybody is, what is something that we think could explain that discrepancy? So, either the overall rate or specifically by gender.
I guess, first of all, maybe could you answer, or you or Ann answer Liz's question that's in the chat, because that's kind of what I was thinking as well.
So it is from the American Community Survey, and so that's just through like questionnaires. So it's the way however they poll for their 1-year, 5-year ACS surveys.
Chris, I'm not familiar with the ACS surveys.
So it's just
and
I mean, it's a general survey. I don't know the exact implement, but I imagine it is something like, you know, what is your basic demographic data, and then they look at, you know, are you employed, are you you know, enrolled in school, and then they go from that.
so they, we don't,
And then it's modeled up to population level.
It's part of the census. So there used to be a long form and a short form census. And then they got rid of the long form in like 2010 or something. And the American Community Survey replaced that. So when you get surveyed, it's like, this is from the census, you have to do this, that kind of thing. Not everyone actually does it, of course, but
It makes me wonder if the young women who are being disconnected, you know, if Barry County has is, you know, I don't think the birth rate for teen pregnancy is much higher in Barry County, but that maybe we don't have the resources to keep those kids in school while that's happening. That's the only gender disparity I could think of that might show that differential, perhaps.
Can
so
you go back to the chart?
Sure, sorry.
Cassie just explained to me that it's the disconnected youth are those who are not in school and they are not working. So the gender disparity could potentially be due to child rearing. I don't know, how old are these people?
16 to
I missed
19.
things. I was looking up something else.
16 to 19 years old.
But you would think that would be statewide.
That's true.
I tend to think that this, again, you know, I guess my thoughts are, I wonder about the correlation with the amount of students that have maybe graduated from high school, but that maybe were surveyed, because you don't really understand, you know, that. And I think I'm understanding what the ACS is and when it was asked, but perhaps they graduated from high school or were not able to enroll in college or didn't have employment at that time. We do have, I mean, before COVID, one of the things that we in mental health, behavioral health, and the substance abuse task force were taking a look at is the amount of kids, young people, youth, age 16 plus, who were not in school during the day, possibly were in virtual academies, and they were not working. And so there was, it would not be uncommon for us to be out and about on a weekday around 1:30 and see a large congregation of young people that would fit this age demographic. And we kind of wondered how that was possible, why they weren't in school or why they weren't working. But, you know, maybe it's just a trend. I don't know.
Cassie, you raised your hand.
Yes, I was just wanting to clarify that the age group is 16 to 24 years old.
Is it? I thought, okay. I thought it was 19. It's strange. Was that on the ACS? Because I mean, that's what I was looking at yesterday, so I don't know if I just missed it.
Yes.
Okay, so 16 to 24 then.
Well, then I think that's, I wouldn't necessarily call somebody 19 to 24 youth. So this could maybe we could rephrase it.
Okay. They're using two
Well,
different
I mean,
age groups. I think the 16, so 16 to 19 is one age group, but they do ask for up to 24. But I think what you pulled was 16 to 19.
Okay. I was gonna say, I'm pretty sure I saw 16 to 19, but okay, so it is 16 to 19. Yeah, so I think we've all discussed, it doesn't seem like there is a particularly known reason. When I saw it, I had to double check it a couple times because it seemed kind of drastic compared to what you see compared to the state. And that is why I wanted to bring it up to see if there was any initial feeling as to what could be going on.
I mean,
Chris, you may want to check the number of people who in this group who are actually surveyed. I'm kind of wondering if small sample size might be a problem here. but it does, but it is kind of consistent over the years. So I don't
And
know.
I mean, so they would have, I think I mean, I don't know for sure because I haven't seen them do it, but I mean, if they had such a small number, I don't imagine they would have published it for the year. So yeah, but like you said, it's consistent. Like you see it rise and now it's kind of falling down. So it's just a weird little thing that popped up when that was available to do the analysis on.
College enrollment by gender. What else? Well, if they were in college, though, they wouldn't be disconnected. They would meet the definition here. So,
well, what I'm saying is if they're not in college, like if for whatever reason, the college enrollment is lower for women versus men in Barry County, which I know the college enrollment rate for Barry County is lower than most other counties in our part of Michigan. So.
Yeah, this is definitely one that we need to take a closer look at before we do the final publication. So thanks to everyone for this discussion.
And so sort of related, it doesn't have, it's not enrollment, but it is educational attainment. And I do go through the same breakdown. So, so these are folks who are over 25 years of age and have at least a bachelor's degree. So we do see that rate of educational attainment, increasing slightly over time in Barry and slightly over time in the state. So the gap has stayed pretty similar over time between the two. And then here again, broken down by gender. So we do see that, the female demographic does have that higher rate generally compared to the state. So it is an interesting sort of swap there. With seeing the disconnected and then coming in and also seeing this. So I don't. Any other feelings on why that might be, or what could be driving kind of both of those?
I wonder if maybe some of the, oh wait, this is educational attainment for all ages, right? Over 25.
For 25 plus, yes.
Okay. Yeah, I wonder if this has to do with, just patterns of people's migration, in and out of the county. So many people who grow up in Barry County don't necessarily go to college there. And so maybe there's different patterns of, coming back into the community. I don't know.
Certainly. Any other comments before we move on to our next one? And our next one then is the percent of households who have broadband internet. And this is defined as having an internet speed of at least 25 megabytes per second down and at least 3 megabytes per second upload speed. So we do see it in Barry County and in Michigan kind of incrementally creeping up over time. But the more interesting breakdown here is on this as the breakdown by income level. So perhaps unsurprisingly, those who have the lowest income tend to struggle with having broadband internet. So it's in one of those situations where it makes things worse. So it makes it harder to get, maybe a higher paying job because you don't have internet, but you can't get that job because you don't have internet. Unfortunately, I know Jennifer had something else going on, so she wasn't able to join us. So I don't know if anybody has any other want to add anything about what they see about internet or anything else, or how they feel how that could be addressed.
I know that there was a survey recently to ask people about their broadband access and internet access. So I do think that there's some interest in doing some work on this for sure. Not sure if anyone on the call has any of that information, but certainly, especially with COVID, we noticed that being, a significant barrier for, people who wanted to make vaccination appointments or people who wanted to get access to information. And then of course, the students who were needing access to the internet for school purposes as well.
And this is Bonnie from the Community Foundation. I serve on the coalition, the Broadband Coalition. And we
Oh,
just
great.
recently, yeah, we just recently received the survey, and we are on the path to do the long-term strategy plan for deployment. And there's a ton of money coming down the pike from ARPA and Build Back Better, or whatever the acronym is, from the president for all of the work that he's trying to get taken care of for us. So there is a lot being done in the area of internet, and Catherine Getty from the County Commissioners is actually the spearhead for all the work. So the county government is strongly behind the work, and I think you'll see a lot of movement. Unfortunately, broadband takes a long time.
That was going to be my question, is what were you feeling maybe the time horizon was on seeing the data move, you know, possibly by the next cycle, or, you know, hopefully not the one after that?
Well, here's the deal. I think what you'll see in the next cycle is the deployment plan. The problem is access to the actual hardware necessary to actually do the work and put broadband in place. There was a grant for MEI that was received by the USDA, but because of the length of time it takes to build out that infrastructure, that grant is over a 5-year period. So it's going to take some significant time before we see a real impact in the work that's being done. Unfortunately, but it is reality.
Yeah, and I don't know if you have the information at all, but do you have the feeling that that sort of thing would, I mean, if not specifically target, you know, that especially that lowest income group there, would that maybe be reaching out to those areas to get that internet service there, or would that be more, you know, all like across the board?
So the problem with making broadband affordable is the lack of real oversight when it comes to how broadband fees are assessed. Yeah, I know that we're all looking at the fact that the most marginal families are the ones that need broadband in the most significant way. But yeah, so we are looking at all of that, and looking at the possibility that, and I know that there were some dollars that came down through the COVID portion that allowed for families to actually be or have their broadband subscription paid for through the United Way. There's been some real push to make it fair and equitable, but I don't think it's going to be anytime soon that we see that.
Well, thank you for all that. It's a lot of really good information and help round it out. So
if you reach out to Jennifer at the chamber, I'm sure she could share with you.
Yeah, she had originally signed up to be here today, and something came up. So I was hoping she would be able to give us all the information, but you certainly gave us a lot to work with too. So and I'm sure we'll hear maybe some more as we move forward with it. So thank you. Appreciate it.
You're welcome. Sure.
Okay. Moving on, our next one will be focused on income and income inequality. So this is our the percent of Barry County households below the ALICE threshold. So these aren't necessarily folks who qualify as impoverished, but at least by the federal definition, but those who have limited income and the challenges associated. So we do see in Barry County that over time it has maintained about the same sort of gap between the county and the state and going down over time. So I'm curious as to if anybody feels like they feel that's still the case, or if there have been some, you know, maybe the data isn't showing the whole picture.
One thing I would add is, of course, this is old data, but you know, in 2020 and 2021, there were a number of, you know, stimulus payments, and especially the child tax credit things, whatever it's called. And I do know that that has been a significant, source of bringing some kids out of poverty. And so I'm thinking maybe that could have an impact on this as well. I don't know.
Yeah, that will be interesting to see over the next couple of years. I think the data so this is the United Way's ALICE report, and I think COVID did delay it by a year. So I think normally we would have had a little bit more updated data, but they just got around to publishing 2019 this year. So hopefully for next cycle it'll catch up and we'll be able to see some of that. So this is our income inequalities. This is our Gini coefficient. So essentially this is saying, we're asking what the difference is between kind of the 80th percentile earners and those who are kind of in the lower portion, the 20th, I think, percentile, and what the difference is there. So we can see, of course, in Michigan, in a state that size, that remains fairly constant over time. But we do see fairly consistent for Barry County as well. And that leads us to our last question in the section. So in the provider survey, so these are the folks who work as medical providers in Barry County. Low household income was listed as the number 3 factor that impacts their patient's health. So with those 2 slides in mind, the ALICE threshold, so the people who are asset limited, and then income inequality, what do we think the difference is there between the providers saying that they feel like low income is a problem, but seeing that there's more income equality in Barry County, and then the ALICE threshold percentage of households going down? What is maybe the difference there?
I think for some people, medical treatment is still so expensive that even if, they're above that ALICE threshold, if you have to go in to go get surgery or go in to go get any sort of procedure where you're in the hospital, you could be looking at, $10,000 of, even with insurance, sometimes you can have these really gigantic bills where they just are out of reach for a lot of people. And I know for at least some of the folks that I work with, they don't want to go into the doctor or into medical providers because they just don't feel like they have the money to pay, even if they have health insurance.
Absolutely. I agree completely. I mean, that was the one thing that popped out to me, is that even with insurance, even with good insurance, it can still sometimes be a lot of money, either to afford the premium or high deductible plans. Having to reach that high threshold is still a challenge, even if you aren't necessarily income limited or a super high earner. It's always still a challenge. Absolutely.
And I would add that, I think, providers may be considering the impact of poverty on all sorts of other things, but not just paying for medical care, but also for their ability to buy healthy food or have access to a positive work environment. I mean, there's lots of different things I think that could be affecting.
And mental health. I think that would, mental health would be, would probably put it up there on the factors.
Right. So the amount of stress that people are under when they are, if they're income limited, if they're an ALICE family, or if they're a family under the poverty level, for sure.
Or unemployed, because I think the E is employment. So if they're not employed, that could be part of it too.
And so we'll move on to, I believe this is our last set of measures. So for here, we'll go going over complete streets policies, housing quality for owners and renters, and then a couple classics in blood lead levels and air quality. So it was requested that our complete streets policies be monitored by jurisdiction. So for this cycle, we have one of the, I think it should be, sorry, one of five, not one of, or one of four, 1 and 4, so 20%. I'll fix that later. But so one jurisdiction out of 5 has a complete street policy, and that is what we wanted to monitor, hopefully going forward. And that is in
Chris?
Middleville. Yes.
Did you include the county as a jurisdiction?
So when I emailed Allison, she said she might come on later. It was one of 5 jurisdictions, is how it was put specifically.
Okay.
I wasn't sure if it was as the county as a whole or specific
Yeah, because I think that,
localities.
yeah, we might want to include the county as a whole because their roads are, I mean, they could have a complete streets policy as well as the, like the cities or villages.
Okay. Thank you. And then we'll move on to our owner occupied housing conditions. And so this one is a little bit of explanation. So a condition here is a house, or in the next slide, an apartment that either lacks complete plumbing, kitchen, has more than 1 occupant per room, and that would be an adult occupant, or having costs greater than 30% of income to have it. So we can see that in Barry, it does pretty well. It's pretty on par with the state overall. So, overall pretty fairly or good conditions for housing. And then for renting, there's a little bit more of a difference there. So the state having more of an issue with the one condition, rental units. And overall, more issues with apartments than with owned homes, which kind of tracks with how things go.
Yeah, and we learned on one of our focus groups that there's a significant rental shortage as well. So, and there's lots of folks leaving the rental market and just not renting anymore. So that's playing into more recently. Like this is again.
Right, this would be 2019. Yep. And so this is our percent of children with elevated blood lead levels. This does have 2020 data on it, so we see both the state and the county headed in the right direction. But they did recently revise the threshold because it was based off a percentile. So this is before that change, so it might be a little bit different heading into the next cycle. But pretty nice to see things moving down. And then our annual concentrations of particulate matter, so very small particulate matter between 2001 and 2016. So that was our last data slide. So before I jump into kind of recapping the community and provider surveys, does anybody have any questions about any of the slides or anything before I head into those? Okay, I'll move on. So just a brief summary of our community survey. Again, we had about 400 responses for this, which is a very good response rate. Access to healthcare and affordable healthcare, not too surprising, were the top 2 responses that people thought kind of made up a healthy community. The next 3 were good schools, affordable housing, and access to behavioral health. So issues affecting Barry County, so their biggest concerns, as I mentioned a little bit before, alcohol and drug issues, followed by that affordable access to behavioral health, lack of access to healthcare, chronic disease, and 2 are tied for the next one at access to nutritious foods and mental health problems. Overall, the community members were in pretty strong agreement that addressing social needs is just as important as addressing medical conditions. They also felt that those who had responded did have the resources they needed to stay healthy and could afford those resources in their community, and did not believe that they had any cultural or language barriers keeping them from receiving care. For our provider survey, access to healthcare, access to behavioral care, and affordable healthcare. Again, unsurprisingly, when you hear it from a provider, we're the top 3 that define a healthy community, followed by healthy, nutritious foods, and playing into that income piece that I had spoke about earlier, good jobs and a healthy economy rounded out the top 5. Interestingly, the providers felt that patients sometimes lacked the motivation to make health conscious decisions while also having a low income, and that did negatively impact the health of their patients. They were also felt that lack of access to healthcare, high cost medications, and an overall lack of education about making those health conscious decisions rounded out the top 5. The most often providers referred out, most often they felt to CMH services or home care and hospice. They also overwhelmingly agree that addressing social needs is just as important as their medical conditions, and do feel that unmet social needs can prevent them from providing quality care, and they don't believe that cultural or language barriers impact the quality of care they provide at this time. And we'll go into a little bit of the things that we gleaned from our interviews from folks. So these were a series of interviews that targeted those who are generally medically underserved. We were able to complete 8 interviews in lieu of being able to do focus groups. And some of the things that came up will be on the next couple slides. So the first one is that COVID has impacted everyone. Nobody in particular noted any significant loss, but they did note those barriers and challenges accessing things that used to be easier, even if they did talk about, it was easier to do things like telehealth or just more social things like visiting family or friends. So that isolation piece and that one quote I had pulled out earlier. Cost of medications, another usual one had come up. Some did feel that their medications were affordable to them, but then in the next sentence did say that they did usually receive some form of assistance for that, whether it was just a negotiated or a discount price. So, if they didn't have those available to them, those medications would not necessarily be affordable to them. Overall, most did say that they enjoyed the small town feel and being close to nature that being in Barry County provides. I had mentioned this one earlier in access to care, that people did not overall feel like there was a barrier, but then there were, similar comments as to people mentioned that they can access emergency resources, viewing that as care. But then they did also acknowledge that if they wanted primary care, that would be a significant barrier to them. And again, another common thing is people who needing specialty care, usually needing to leave the area for especially higher level specialty care. In terms of mental health, there were a few who mentioned it specifically, but those who did were a little bit concerned with just their experiences with the Barry County Community Mental Health or just ability of people in general to seek help. Again, that's just one experience. And overall, like we said, we've mentioned a couple of times pre-COVID, but COVID has certainly contributed to more overall stress for people, throughout the whole pandemic time. And when it comes to relationships with their providers, kind of a mixed result. Some did feel like they were listened to and participate, while others felt like they were kind of talked down to or ignored. Kind of the things you hear all the time when it comes to provider relationship. Among the things that were listed to make it easier to be healthy in the area, folks spoke highly of having a lot of parks and outdoor activities. But that was during the warmer months. When it gets cold out, they felt it was harder to stay active. There are gyms and pools available, but it is hard to, get to them sometimes depending on the traveling conditions. And most people did just like being able to go outside and take a walk and enjoy being outside. And again, easy to find, low-cost processed foods compared to those higher quality, minimally processed foods, so the nutritious fruits and vegetables. And with that, we'll move to our next steps. So what's going to come up? So how overall is today going to influence what we do? So some of the discussions, this is recorded, so we will go through it, we'll look at it, we'll listen to it. It'll be posted for folks who miss it, but it will also influence the way that we do things going forward. So like if we felt like we missed something, so we made a couple comments about wanting to include something new, we will include those and we'll get the data for it to paint that complete picture. If we felt like we missed anything, We will develop the layout and final publication, which again is targeted to be near the end of the year. Once that is out there, we will get it broadcasted out far and wide once that is available. But first comes prioritization. So Anne, if you could put the link in the chat. Hopefully you've already seen an email from us. So at the same time this invite went out, the invite went out for prioritization because they're kind of a two-piece of the meeting. So we look at the data here, we decide if we're at that full picture of data we want. And then once we have that, we can move to prioritization. So I will send out the summary of the summary slides that you've seen throughout here, and maybe a few others to make sure everybody who wasn't here is able to see them, at least in summary form. And then we will prioritize those health issues. So they'll be grouped up. Instead of having individual measures, we'll group them into kind of similar areas to give us more broad targets to focus on instead of looking at kind of those minor details. So more things are able to affect those priorities we do choose. And registration is open. So Anne, thank you for putting it in the chat. And with that, I would just open the floor to any questions or comments or concerns going forward.
Liz had a question about any mention in any of the collection sources about concerns about marijuana use or access. So was that included in the provider survey or the community survey? I think maybe it was lumped in with like alcohol and drugs.
I think it was lumped in, like you said. There's no specific measure for that that was included this time around. I'm trying to think, and does our BRFS have a question specifically about it?
Yeah.
So one of the things that I'm just remembering to mention is that there was a request to include all of our BRFS measures in the final report. So that is where that data will come from. So we have that in our survey, and that will be included in the final report, even if we didn't go over all of the BRFS measures at this meeting, just for the sake of time. Any other comments or questions about what we've seen today?
Can I ask a question? The very first map that you showed, and it showed resources versus what were the things that were labeled?
The blue were the top 50 employers, and places of in Barry County, and then the purple ones were the resources that folks could use if they feel they need them.
So what kind of resources did the purple include?
So there were libraries, and there were, I can't remember. There's going to be a full list in the report. So the two I remember off the top of my head are like Michigan Works, employment services, those things, and then like libraries and places you can receive other ways to increase your employment skills.
I think it was job seeking assistance resources.
Yes.
Gotcha. Job seeking. Got it. Okay. Thanks.
So this is Liz. I guess my question that I typed in the, not to be redundant, but my question that I most recently asked about and mentioned in any of the collection sources about concerns about marijuana use and access, and I can assume then that questions were not asked specifically about opioids or the current opioid epidemic. They were maybe all lumped into alcohol and drugs.
I believe that is how they were asked. Cassie, is that right? I'm pretty sure they were all lumped.
You are right.
Okay, thank you.
And I am unmuted.
Okay, if anybody has any other questions from here, Anne and I will stay on for a little while to answer those. Otherwise, thank you so much for joining us. I do plan on posting this recording to YouTube, so it is recording, and then hopefully before Thanksgiving, I'll be able to get it trimmed up a little bit and then posted to YouTube and sent out so everybody can have it. Everybody here hopefully already has a copy of the slides. So if you need to hear the recording, you'll have them both on hand. So again, thank you everybody for joining, and have a nice day. And as Kathy said, see you on December 13th.
Hey, Chris, this is Allison. Sorry, I joined late, so my lack of questions is probably because I didn't hear the majority of the presentation.
No worries.
Is there a date for feedback, like a timeline for when you want to hear back from people once I've watched the recording?
I mean, I will leave that to Cassie because she's writing the final report. At this point, we have most of the things locked in, so I wouldn't think, you know, 1 or 2 measures would be an issue. But Cassie, I will kind of defer to you on that.
And I would like, I think it would be reasonable if you have any suggestions that they get to us by what is the 3rd of December, so that we have time to see if that information is obtainable,
Okay,
so that we could consider including it.
thank you.
Okay. Yeah, I think the 3rd is enough time to see whether it's available or not, and to be able to include it if that's possible.
Yeah, I mean, that sounds roughly right to me too. If you need any help with it too, yeah.